Hello, everyone. I'm Dr. Li Ping from Department of Gastric Surgery, Fujian Medical University, Yulin Hospital. Today, we are going to talk about management of the injured patient. This figure showed epidemiology of trauma in 2007 in the United States. From this figure, we can see unintentional injury is the first cause of death before age 65. Trauma deaths have been classically described as having a trimodal distribution with peaks that corresponding to the types of intervention that would be most effective in reducing mortality. The first peak, immediately death, represents patients who die of their injuries before reaching the hospital. The injuries accounting for these deaths include major brain or spinal cord trauma and rapid exsanguination. Prevention remains the major strategy to reduce these deaths. The second peak, earlier deaths, are those that occur within the first few hours after injury. There are many caused by internal hemorrhage and central nervous system injuries. Well-organized and trauma systems with rapid transport and protocol gravity care is the important management. The third peak, the late deaths, consists of patients who die days or weeks after injuries. 61% are caused by sepsis and multiple organ failure. Evidence suggests that at present, as many as 30% of the late deaths could be prevented by improved critical care management. How does the trauma system work? Trauma data connection, trauma data analysis, trauma system performance improvement. From pre-injury, pre-hospital care, inpatient trauma care, and post-acute care, we should pay attention to all these procedures. The immediate measures at the scene of an accident is very important for the injured patient. Is the victim breathing? If not, provide an airway and establish back mask, mouth-to-mouth ventilation. Is there a pulse or heartbeat? If not, begin closed chest comprehension. Is there gross external bleeding? If so, evaluate the part if possible and apply enough external pressure to stop the bleeding. Is there any question of unique to the span? If so, protect the neck and span before moving the patient. Splint obvious fractures. Whether the patient is first seen on the battlefield, beside the road, in the emergency ward, or in the hospital, the basic principles of the initial management are the same. As soon as all these steps have been taken, the patient can be safely transported. In most cases, the history is obtained from pre-hospital personal radio communication or when the patient arrived at the hospital. Trauma victims require a precise, rapid, systemic approach to initial evaluation in order to ensure their survival. The sequence of evaluation includes preliminary survey, resuscitation, secondary survey, and definitive management. Preliminary survey include C, A, B, C, D, E. C means catastrophic hemorrhage control. A, airway. B, breathing. C, circulation. D, disability. E, extremity. Airway. The establishment of an adequate airway has the highest priority in the preliminary survey. These three figures show three ways to keep airway patency. First one, relief of airway obstruction. Second, up is the natural tracheal intubation. Down, the oral tracheal intubation. The third figure shows the surgical coracostyloidotomy. E, the breathing. Once the airway has been established, it is necessary to make certain that ventilation is adequate. Examine the patient to determine the degree of chest tension, breath sounds, tachypnea, crepitus, floor rib fractures, subcutaneous emphysema, and the presence of penetration or open wounds. The immediately life-threatening pulmonary conditions are tension pneumothorax, open pneumothorax, flare chest, and occasionally massive hemothorax. C. Circulation. Gross hemorrhage from accessible surface. Wound is usually obvious and can be controlled in most cases by local pressure and the evaluation of the part. This figure shows applying a tourniquet with a windlass device. All patients with a significant trauma should have a large capital intravenous catheter inserted immediately for administration of drugs and fluids as needed. If any degree of shock is present, at least 2 intravenous lines should be inserted. As soon as the first intravenous line is inserted, rapid cholesterol infusion should be given. Patients should experience a transient response should receive an additional infusion of 2 liters of cholesterol. Neurology disability. Various stages of coma due to a variety of causes may accompany injury and require treatment during resuscitation. This table showed the Glasgow Coma scale. Best motor response, best virtual response, eye-opening. The GCS score is useful in monitoring acute changes in neurological function and is used for prognosticating outcomes after severe head injury. The motor component of the GCS score is the most accurate for predicting outcome and has a linear relationship with mortality. E. In exposure, all clothing should be removed from the seriously injured patient with care taken to avoid unnecessary movement. All skin surfaces should be examined to identify acute injuries that might not be readily apparent. After inspecting all surfaces, warm blankets or arm devices should be placed to avoid hemothermia in the seriously injured patient. Resuscitation phase. First, shock. Shock is defined as inadequate end organ tissue perfusion. Inadequate organ perfusion and delivery of nutrients necessary for normal tissue and ciliary function initially might be reversible but life threatening if not treated promptly. For hypovolemic shock caused by hemorrhage, dehydration, burns, skin is cold, clammy, PCWP is increased, SVR increased. Treatment IV fluids. Obstructive shock, for example, caused by cardiac tamponade, pulmonary embolism, intention phenomenal thorax. The skin is cold, clammy. Treatment relieve obstruction. This table shows the classification of hypovolemic shock according to blood loss, pulse rate, blood pressure, pulse pressure, ovary loading output, and mental status. Class 1, Class 2, Class 4, Class 3, Class 4. This table shows the hemodynamic patterns associated with specific short status, type of shock, cardiac myocardial inaction or cardiac tamponade, hypovolemic hemorrhage, intravascular volume depletion, distribute shock, obstruction. All these words, the abbreviation is down. For example, CI cardiac index, SVR systemic vascular resistance, up L increased, down L decreased, N normal. For example, hypovolemic CI decreased, SVR increased, PVR normal, SV oxygen increased, RIP increased, decreased, RVP decreased, PIP decreased, PR decreased. This flow chart shows the management of undifferentiated shock. Approach to the undifferentiated shock. First, data review, vital sign or lab change, recent procedures or medication change, relevant history. Besides exam, including general appearance, skin perfusion, echocardiogram, non-US to exclude pneumothorax, abdominal exam, cause identified. For the first investigation, treatment, for example, joint pneumothorax. Cause remains unclear. Further labs, potentially including vascular labs, lactate, if infection suspected, cultures, urinalysis, if infected suspected, APX studied, procalculation, if hemorrhage possible, type and cross-match blood. Radiological studies, EKG occasionally helpful, chest X-rays, formal echocardiogram, if besides an exam, vocal, CT scan depend on scenery, for example, CT abdominal, pelvic to look for septic focus, then stabilizing to consider, even before diagnosis is clear. For example, with operations, epineural drip, or fluid, and so on. Secondly, survey means a rapid and complete history and physical examination. Recognition of injury pattern is also important in identifying all injuries. Secondly, survey is a head-to-tail evaluation of the patients. In all cases of multiple injury, there must be a captain of the team who directs the resuscitation, decides with X-rays or special diagnostic tests should be obtained, and establishes priority for care by continuous consultation with other surgical specialists and anesthesiologists. A trauma surgeon or generally surgeon experienced in the care of injured patient usually has this role. Details of the definitive management of the injuries are discussed in the sections on trauma that are flow and in the various organ system chapters of this next book. First, neck injuries. Clinical findings. Injuries to the larynx and trachea. Hoarseness. Laryngeal stridor. Dyspnea. Cervical spine fractures and spine cord injuries. Cervical pain, tenderness, deep breast consciousness. Esophageal injuries, severe chest pain, and dysphagia. Progressive sepsis. Vascular injuries, visible external blood loss, neck hematoma formation, varying degrees of shock. These two figures show the types of injuries. Penetrating neck injuries, for example, use a knife. Blunt neck injuries, for example, use a small ball. This figure shows the zones of the neck. Zone 1, Zone 2, Zone 3. Diagnostic. With any penetrating cervical trauma, the likelihood of significant injury is high because there are so many vital structures in such small space. Arteriography can be performed to identify the arterial injuries. Ultrasound with color flow Doppler may be used to rule out carotid injuries. Rigid endoscopy can be used to evaluate the tracheal and esophageal xyloids of the soft tissues, and the cervical span should be taken routinely. Careful neurological examination can differentiate between the injuries to the cord, brachial plexus, and the brain. Complications. The complications of untreated neck trauma are related to the individual structures injured. Injuries to the nuncus and the tracheal can result in acute airway obstruction, left tracheal stenosis, and sepsis. Cervical mediastinal sepsis can result from esophageal injuries. Carotid artery injuries can produce death from hemorrhage, stroke, or cerebral arrhythmia, and arterial venous fistula with cardiac decompensation. Major venous injury, strangulation, air embolism, and arterial ovation, fistula formation, severe fracture, paraplegia, quadriplegia, or death. Treatment. Management of severe neck injuries. First key, earlier intubation. Then, penetrates the plasma, prompt surgical exploration or diagnostic workup. Zone 2 injuries. Color flow job imaging might provide a reliable way to access. For vascular injury, can be a safe alternative to contrast angiography. Arteries damaged by high vertical methods. Debridement, end-to-end anastomosis of the mobilized vessels. Autogenous vein graft can be used. Management of a massive hemorrhage. Ligation with surgical clips or light to the vessel between the transverse processes above and below the circulation is accepted. Subclavian artery injuries. Proper exposure and ligation of the subclavian artery. B. Avoid phalanx nerve and thoracic duct injury when operating in this region of the neck. C. Endovascular stent. Venous injuries. Ligation. A simple means of preventing ligation complication is to lower the patient's head using the Trendelenburg position. Esophageal injuries. Sutured closed primarily. Fourth, thoracic injuries. Airway obstruction. Open phenomenal thorax. Flare chest. Tension phenomenal thorax. Massive hemothorax. Pericardial tamponade. This figure shows the anatomy of the thorax. This figure shows the etiology of the thoracic injuries. Road traffic accidents account for 32%. Firearm injuries account for 19%. Faults 22%. Domestic violence or trauma 5%. Staple injuries 12%. Occupational injuries 5%. Plaster injuries 4%. These figures show the types of injuries chest wall. The rib fracture, the first picture, rib fracture. Second, sternal fractures. Rib fracture. The most common chest injury varies across a spectrum from simple fracture to fracture with hemophilomosis to severe multiple fractures with flare chest, pulmonary contusion, and internal injuries. With simple fractures, pain on inspiration is the principal symptoms. Treatment consists of providing adequate analgesia. These are types of injuries: tracheal and bronchial. Left, blunt trauma. Right, penetrating trauma. This figure shows types of injuries: tracheal and bronchial. Diagrams of principal post-intubation tracheal lesions. For example, A. Cuff sinuses from the scalp of an endotracheal tube. This figure also shows the injuries types of tracheal and bronchial. This is normal. Level 1, Level 2, Level 3A, Level 3B. Post-intubation tracheal or bronchial laceration also include morphological classification based on the depth of the tracheal wall injury. Here. So this is the approach for a contemporary treatment of tracheal or bronchial injuries. For example, suspected airway injury, CT image and or for bronchoscopy. Level 1 or Level 2 injury. If impending respiratory failure, we can use the bronchoscopic intubation, bronchoscopic evaluation, and ED curve adjustment. If Level 3A and B injury, intubated ventilation failure, then ECMO, multidisciplinary management or surgical repair. Intubated self-ventilation, bronchoscopic ET cuff adjustment, surgical repair. If for level 3A and B injury, poor surgical candidate, spontaneous respiration, intubated, impending respiratory failure, then multidisciplinary management also use stent considerations. Exhibit shows the types of injuries pulmonary space. Pneumothorax, pneumothorax. Pneumothorax, this is the normal lung. Pulmonary cavity. This shows the collapsed lung. This is the air. And the hemothorax. This is the collapsed lung. And this is the blood, is red color. Hemopneumothorax with air and blood in the pulmonary cavity. This is the collapsed lung. Okay, we are talking about pneumothorax. This is the open pneumothorax. Inspiration, air in. Expiration, air out. Open pneumothorax. This condition results from an open wound of the chest wall with free communication between the pulmonary space and the atmosphere. The resulting impairment of the thoracic billows and its ability to expand the lung, resulting in inadequate ventilation. With chest expansion during a breath, air moves in and out of the chest wall opening instead of through the trachea, producing hyperventilation that can be rapidly fatal. Emergency treatment consists of sealing a wound with an occlusive sterile dressing taped on 3 sides to act as a flutter type valve, or with any material if nothing sterile is available. Tension pneumothorax. This figure shows left inspiration, right expiration. This condition occurs when air becomes trapped in the pulmonary space under pressure. The clinical findings consist of hypertension in the presence of distended neck veins, decreased or absent breath sounds on the affected side, have response to percussion, and tracheal shift away from the affected side. Cyanosis may be a late manifestation. How to treat? Emergency treatment consists of insertion of a large bore needle or plastic intravenous cannula through the chest wall into the pulmonary space in the second intercostal space along the mid-clavicle line to relieve the pressure and convert the tension pneumothorax to a simple pneumothorax. The needle or cannula should be left in place until a thoracostomy tube is inserted for definitive management. Flare chest. Multiple rib fractures resulting in a free floating segment of chest wall might produce paradoximal motion that impairs lung expansion. In patients with flare chest, injury-associated pulmonary contusion is common and is often the major cause of respiratory failure. The injury is identified by careful inspection and palpation during physical examination. Patients with large flare segments will also always require endotracheal intubation and mechanical ventilation, both to stabilize the flare segment and to optimize gas exchange. Small flare segments may be well tolerated if supplemental oxygen and adequate anesthesia are provided. The work of breathing is increased considerably, and many patients who initially appear to be compensating may suddenly deteriorate a few hours later. Therefore, most patients with flare chest require monitoring in an intensive care unit. Types of injuries. This is lung injuries. Pulmonary contusion due to a standard parenchymal occlusion occurs after blunt trauma or wounding with a high-velocity missile. Pulmonary contusion occurs in 75% of patients with flare chest, but can also occur following blunt trauma without rib fractures. This figure shows types of injuries, lung injury. The clinical findings are complications, blood tangent saturation, chest pain, restlessness, apprehensiveness, and robot respiration. Eventually, dyspnea, cyanosis, tachypnea, and tachycardia developed. This shows the types of injuries: heart pericardium. Blunt injury to the heart occurs most often from compression by steering wheel in auto accidents. The injury varies from localized contusion to cardiac rupture. Earlier clinical findings include friction rubs, chest pain, tachycardia murmurs, dyspneas, and signs of low cardiac output. This figure shows the Types of injuries: heart and pericardial, blunt cardiac injury with a small baseball or fist or envelope. Management of myocardial contusion should be the same as for acute myocardial infection. Treatment of penetrating cardiac injuries requires prompt thoracotomy, pericardial decompilation, and the control of hemorrhage. This is EKG findings in blunt cardiac injuries. We can see this picture also shows the penetrating cardiac injuries. Esophageal population. Anatomically, the esophagus is well protected, and the perforation from external penetrating tumor is relatively infrequent. The most common symptom of esophageal perforation is pain. Fever develops within hours in most patients. Contrast exercise of esophageal should be performed but are positive in only about 70% of following perforation. A nasogastric tube should be passed to evacuate gastric contents. If recognized within 24 or 48 hours after injury, the esophageal perforation should be closed and the perineal drainage instituted with large bore catheters. This figure shows the esophageal perforation here. We can see the exercise. Types of injuries: thoracic, penetrating injuries of the neck, thorax, or upper abdomen can injure the thoracic duct or its major tributaries. Symptoms are due to mechanical effects of the accumulations. Example: shortness of breath from lung collapse or low cardiac output from temporal load. The diagnosis is established when the fluid is shown to have characteristics of jelly. The patient should be maintained on a fat-free, highly carbohydrate, high-protein diet, and the infusion escalated. Chest tube drainage should be instituted if the infusion recurs. Total parenteral nutrition with no oral intake may be effective in treating persistent leaks. Diaphragm. Wounds of the diaphragm must not be overlooked because they rarely heal spontaneously and because herniation of abdominal viscera into the chest can occur with catastrophic complications either immediately or years after the injuries. Associated injuries are usually present, and as many as 27% of patients are in shock when first seen. There may be abdominal tenderness, dyspnea, short pain, or altilateral breath sounds. The diagnosis is often missed. Although the chest radiography is a sensitive diagnostic tool, it may be entirely normal in 40% of cases. CT scan or contrast exercise might be necessary to establish the diagnosis in some cases. Laparoscopy might prove to be a useful technique for detecting occult diaphragmatic injuries in patients who have no other indications for formal laparoscopy. Once the diagnosis is made, a trans-abdominal surgical approach should be used in case of acute rupture. Laparoscopic surgery for repair of the injury may be possible in selected cases. Abdominal injuries. If the abdomen is the probable source of strangulation hemorrhage, the patient should be transferred to the operating room for immediate laparoscopy. ET have two types of injuries: penetrating tumor. Penetrating tumor injuries might cause sepsis if they perforate a hollow viscus. When a full bore is injured, the contents are evacuated into the peritoneal cavity, and clinical signs of injury are obvious. When an empty bore is inserted or injured, or when the retroperitoneal portion of the bore is penetrated, spillage of bore contents may be negligible initial, and findings may be minimal. Penetrating injuries cause severe and earlier shock if they involve major vessels or the liver. Penetrating injuries of the spleen, pancreas, or kidneys usually do not bleed massively unless a major vessel to the organ is damaged. Left shows the blunt tumor. A major addition in management of blunt tumor has been first assessment with sonographic for a tumor fast examination. Ultrasound has proven to be an ideal modality in the emergency evaluation of the tumor patient because it is rapid and accurate for the detection of intra-abdominal fluid or blood. Is readily repeatable. In the standard fast examination, 4 areas are scanned: the right upper quadrant, the subsigmoid area, the left upper quadrant, and the pelvis. This table shows the diagnosis method for abdominal tumor. Method: physical examination, time, quick, low cost. Advantages and disadvantages. Useful for cellular examinations, very limited by other injuries. Comma, drug intoxication, poor, sensitive, and specific. Diagnostic pelvial lavage, quick, inexpensive. Rapid results in unstable patient, but invasive and may be vulval sensitive for blood and not specific for site of injury. Requires experience and may be limited if previous surgery. First assessment with sonography for tumor. Fast, quick, inexpensive. Advantage and disadvantage. Rapid detection of intra-abdominal fluid and pericardial tamponade may be limited by or later experience. Large bore habitals, subcutaneous air, poor for detection of bore injury, fairly sensitive but not highly specific. Helical computerized abdominal tomography, the CT, time slower, cost is expensive. Advantage and disadvantage. Most specific for site of injury can evaluate ritual peritoneal. Very good sensitivity but might miss bore injury. Risk of reaction to contrast dial. Picture showed the focused assessment with sonograph for trauma faster. Focused assessment with sonograph for trauma. This picture showed the diagnostic peritoneal lavage. Diagnostic peritoneal lavage is designed to detect the presence of intraperitoneal blood. Additional terminations of leukocytes, particulate matter, or amines in the lavage fluid may indicate the presence of a bore injury. Drainage of lavage fluid from the chest tube or urinary catheter might indicate a lighted diaphragm or blood. The indications for the diagnostic peritoneal lavage include abdominal pain or tenderness, low abdominal rib fractures, unexplained hypertension, spinal or pelvic fractures, paraplegia or quadriplegia, and assessment hampered by all mental status due to neurological injury or intoxication. The only contraindication is need for emergency laparoscopy. CD is non-invasive, qualitative, sensitive, and accurate for the diagnosis of intra-abdominal injury. This is the criteria for evaluation of the peritoneal lavage fluid. Positive for bacteria on glands and smear bile. Intermediate, negative. And laparoscopy has an important diagnostic role in stable patients with penetrating abdominal tumor. It can quickly establish whether peritoneal penetrating has occurred and thus reduce the number of negative and non-therapeutic tumor laparotomies performed. The three main indications for exploration of the abdominal falling blind tumor are peritonitis, unexplained hypovolemia, and the presence of other injuries known to be frequently associated with intra-abdominal injuries. These pictures show the normal abdominal CTs. Okay, next, how to treat. For example, the abdominal wall injuries, penetrating abdominal wall injuries, show that debridement and education are appropriate surgical treatments. Abdominal wall defects, insertion of a subbubble mesh or coverage. This picture shows the hernia, the abdominal wall defects. This table shows the pattern of injury in blunt abdominal tumor. Spleen injury in the first place accounts for 40.6%. The second is the intestinal and the liver injuries, account for 15%. Then the retroperitoneal hematuria accounts for 13%. Then the kidney, 12%. Urinary blood, 6%. Mesentery, 5%. Pancreas, 3%. Vascular, only 2%. Stomach is the last place, only 1.7%. This picture showed the grades of injury for spleen. Have 1, 2, 3, 4, 5. Have 5 grades of the injury for spleen. This is the flowchart of treatment for the splenic injuries. For adult patients, spleen tumor, hemodynamical stable, contrast enhanced CT scan plus local exploration. If the minor lesions, use the non-operative management. Then consider angio if positive blush or earlier Angeles pass. If the moderate lesions, then the angiography. If positive blush or earlier anomaly, no free ambulative angioembolization or serial clinical, laboratory or radiological evaluation, or consider angio if indicated. Then, if the hemodynamic clinical stability absence of other indication to laparotomy, yes, continue non-operative management. No, laboratory plus splenectomy or splenic salvage. Then, spleen tumor, if hemodynamic unstable or transient responders, positive or fast, then severe lesions, also use laparotomy. This figure shows the grades of injury for liver. Also have 5 grades for the liver injury. For example, grade 2 have 1 to 3 centimeter depth, less than 10 centimeter diameters, account for 10 to 50% surface area. Regulation intraparenchymal hematoma, subcapsular hematoma. This flow chart showed the treatment for liver injuries. Blunt alternating. Left. Hemodynamical stable. Contrast enhanced CT scan plus local exploration. Minor lesions, moderate lesions or severe lesions. To free air, become free air localized second bowel. Evisceration, impairment, peritonitis. No. Positive plus. No. Surgical clinical laboratory or radiological evaluation. Consider angio if indicated. Positive plus, yes. Ineffective angio penetration to operating room. If hemodynamic clinical stability, absence of peritonitis, free air, localized seeking bowel, no. To operating room, yes. Continue non-operative management. If the blunt or genital liver injuries lead to the hemodynamical unstable condition, means severe lesions, we should go to the operation room to have a surgery or angioembolization. This figure shows Strasbourg classification of bile duct injuries. Have 5 types. Also, this flowchart shows the treatment of biliary tract injuries. For bile duct injury, example, post-operative diagnosis, less than 3 weeks, AOD type injuries, percutaneous drainage and/or ERCP and stent. If complex injuries, BC, type B, type C, or type E1 to E5, percutaneous drainage and/or ERCP and stent. Delayed secondary repair with biliary digestive anastomosis after 6 to 7 weeks. If bile duct injury, post-operative diagnosis greater than 6 weeks, stenosis type E1 to E5, have ERCP and stent or biliary digestive and anastomosis, or hepatic resection if stenosis and intrahepatic, or liver atrophy, and liver transplantation if secondary biliary cirrhosis or diffuse circulation cholangitis. This showed the pancreatic injuries. I have grade 5. Grade injury. For example, grade 1 hematomy, minor contusion without duct injury. 5. Laceration, massive distribution of pancreatic head. This is a flow chart showing the treatment of pancreatic injuries. Trauma event, isolated low energy mechanism to suspected pancreatic injury plus ductal injury, MRCP plus or ERCP, severe, high grade, ductal injury present, or no grade, no ductal injury. If ductal injury present, use the ERCP, surgical resection, or stent, failure to surgical resection. For no ductal injury, symptomatic care, pain management, earlier enteral feeding, mobilization. Next, gastrointestinal tract injuries. Severity of injuries, grade 1, grade 2, grade 3. Endoscopic findings for grade 3, ulcer and or hemorrhage. Pathological findings, grade 1, minor or no loss of mucus. Grade 2, injury to submucous or muscle layer. Grade 3, injuries through interval penetration or perforation. Treatment, we should go to the operation room to subtotal or total resection. Lateral repair, duodenectomy tube, distal jejunal stomy feeding tube, operative evacuation, 2-layer sutured closure, fecal stream or externalized. Genitourinary tract injuries. This figure shows the grades of injury for kidney, also have 5 grades. This figure shows the flow chart of treatment renal injuries. Suspected blunt renal tumor, hemodynamical unstable, then emergency laparotomy, pulsatil expanding hematoma, then renal exploration, use the reconstruction or nephrectomy. If the condition is stable, then visible hematuria, contrast enhanced CT scan with urographic phase. Grade 1 to grade 3 observation, consider discharge if lung visible hematuria, or if branch artery bleeding, angioembolization. Grade 4 to 5, conservative management plus angioembolization. If renal artery or vein or pelvic ulcer, renal exploration. Urethral injuries. This is a common site of injury. Pelvic brain, tunnel of Watson. So this flowchart shows the treatment for urethral injuries. Suspected urethral injury. distomic and retrograde or unitary noscopic injury, unitaric stent and or unitonal Kessler, successful close monitoring of urine output and renal function and postoperative CT. Then reassess extent of unitaric injury with CT and or unitoscopy and decide on definitive management. Lung surgical management. Then surgical management, open or laparoscopic unitary nanocystomy or open or laparoscopic unitolateral ostomy. If unsuccessful, percutaneous nephrostomy and antegrade stent. Unsuccessful, laparoscopic exploration and repair. Open exploration and repair. No injury. Electronic stent is possible, but not mandatory. Then close monitoring of urine output and renal function plus postoperative intravenous or CT urogram. This is a picture showing the blood injuries, lecture of the blood. Uniceral injuries have 5 types. Uniceral injuries. For example, type 1, stretching injury to the prostatic unicell but no displacement. Note, rupture of the opulostatic ligaments. This flow chart shows the treatment for urethral injuries. For example, suspected urethral injury, retrograde urethrogram, then prostatic membranous disruption, then partial rupture to if blunt injury. Suprapubic cystotomy. If no stricture, then follow up. Thank you for your attention.